Good evening, everyone, and welcome to another PCOS Girl live series. I am so excited about our conversation that we're going to have tonight with the PCOS psychologist, Gretchen Kubacky. She is a wealth of knowledge, and we're going to touch on some elements that are really important and often overlooked with PCOS. So hang tight with me for a minute because I'm just waiting for Gretchen to get here so we can start our live. I hope everybody has been enjoying this month's content. We've covered a lot of different topics and we still have more coming up this week, so please stay tuned for that. We have some great guests for the rest of the week, and we even have, for the very last day, a cooking demonstration, which is going to be awesome. Give me just 1 second. And I am going to get Gretchen online with us. Okay, she should be here any moment. And there she is. Hello, Gretchen.
How are you?
I am phenomenal now that you're here. How are you?
Good. That's because I finally learned that I have to be on my phone to do these things.
It's okay. It's a learning curve. It took me like a year to figure this out, but now you can't stop me. So I have a feeling it's going to be the same for you as well.
All right.
So everyone, here is the PCOS psychologist, Gretchen Kubacky, and I am so excited to have you here tonight because this is a topic that we're going to talk about that is really overlooked and misunderstood. So before we dive into it, I would love you to tell everyone a little bit about yourself and your practice and how you got involved in PCOS.
Sure. So I am located in Los Angeles, California, where I have a private practice, which at this point is all online because of the pandemic. And I work with chronic illness and grief and loss, which has a lot of overlap. I mostly work with adults at this point. I sometimes see teenagers. I've written a book called The PCOS Mood Cure, Your Guide to Ending the Emotional Roller Coaster. I founded PCOS Wellness, which is a website that has a lot of great material on it for free. And I am involved with PCOS Challenge on the PCOS Challenge Board of Advisors. I often do speaking, writing, interviews like this, all sorts of things. And the reason I do this, of course, is that I am a PCOS patient. And I was diagnosed back in the dark ages when they'd throw a pack of birth control pills at you and say, good luck.
Yes, I know that all too well.
So I think it should be better than that.
Yeah, and we're working towards that. And, you know, it seems like we haven't made a lot of advances, but really, I guess I can say, I know this is going to sound really funny, but in 23 years, I've seen a lot of change. And it might take another 23 years for things to really be where they need to be, but at least we're going in the right direction now.
Yeah, I'm thinking about that. I think I've been doing PCOS specific things for about 15 years at this point, and there definitely has been improvements in it, but there's also still a long way to go. So
yeah, and that's one of the things that we're going to talk about tonight, because a lot of the focus with PCOS continues to be on women of reproductive age. So that really means that the focus is just on reproductive needs of patients, and we're often missing the hormonal, the metabolic, and what we're going to talk about this evening, the psychological issues that may come up with having PCOS. Some might be hormonal and some may be from dealing with the symptoms of PCOS. So, oh boy, Gretchen, where do we start with all of this? Why is it so important to talk about mental health with PCOS?
Well, the really big reason, I'll just start off with the big startling fact, which is that 7 times more PCOS patients die by suicide than non-PCOS patients. And that really underscores the fact that there is a phenomenally higher level of depression, of anxiety, of eating disorders that may lead to thinking self-destructive thoughts or behaviors. There's a lot more issues that can also lead, they're kind of complicated, that cross over between mind and body. So for example, sleep apnea, OSA, obstructive sleep apnea, is a diagnosis that is supposedly treatable in the mental health world. It would be treatable for me because it's a behavioral health issue. but it's really a medical issue, right? And that is something where we see, in any case, non-PCOS people, 50% of the people over age 50 have obstructive sleep apnea. We have even higher rates among PCOS patients. If you're not getting adequate sleep that's restorative, reparative, it's contributing to or causing anxiety, depression, eating disordered behavior, and so many other things that could possibly be going on, particularly if you have something else, a more severe diagnosis like extreme depression, bipolar disorder, schizophrenia. Everything being normalized and having consistent sleep, consistent eating, all those things really help to support you when you are having mental health conditions. So this is part of why it's important. And what I said about mind body is the mind and the body are not separate. And particularly, our hormones are in every cell of our bodies, top to bottom. So it affects our minds, it affects our brains and how it functions. We also see a lot of gut disorders in people with PCOS. So we see a lot of things ranging from indigestion to diarrhea, hello metformin, constipation, low appetite, excessive appetite. Most of our feel-good hormones and chemicals are produced in the gut. So the serotonin comes from the gut. If your gut's off, your brain's going to be off. It's just, all of it is a big circular sort of thing where one behavior or experience or diagnosis feeds into the other ones. So unfortunately, the way we are mostly treated is as separate bits and pieces. Go see the GI doctor, go see the orthopedic doctor, go see the psychiatrist. And that is helpful to an extent, but you really need to look comprehensively at it.
Absolutely. Especially because a lot of patients that are dealing with PCOS, when they go to see their provider, a lot of times they're telling them, it's not that bad, suck it up, just lose weight, just take a pill. And it leaves a lot of patients feeling isolated and desperate. So what messaging needs to change there? I mean, with the providers to understand that this has a profound impact on our overall health and life.
Yeah, I think a lot needs to change with that. And in particular, gynecologists, who often are the primary care providers, if not the only care provider for female patients, need to have more awareness of the possibilities of managing it without birth control pills being part of the equation. Also, to focus on the fact that PCOS is something you're born with and you're going to die with it. It is not just about reproductive age. And it doesn't mean that PCOS is resolved even if you have a hysterectomy. You still have PCOS, because what it really is a metabolic syndrome, not a reproductive syndrome. And so the messaging that needs to change, first of all, is you're in charge of this. This idea that if you eat less and exercise more for PCOS patients, almost inevitably ends up as an eating disorder. It does not result in weight loss. I see patients who lose a lot of weight, and it is usually because of severe restriction. And that is not healthy in the long run. It does not support good health. So this idea of restricting, being told by doctors who have very little nutrition training, oh, follow this diet, follow that diet, I think is really ill-conceived idea, and is something where they need to know to refer out to people who have expertise in PCOS, people who have expertise in nutrition that is sensitive to metabolic disorders, especially PCOS. That's where we start to change things. Also, for people to be trained in terms of awareness, like for personal trainers, going harder, faster, longer is counterintuitive. It causes an elevation of stress hormones. A little bit of that is great. Too much of it becomes a self-perpetuating thing where you can't lose weight because your body is in such a state of stress. And also, losing weight should not always be the goal.
Right. Exactly. So how do we change mindsets? Because I know for the longest time, and I still have my moments, you feel like it's your fault because you're made to feel like it's your fault. And because you feel that it's your fault, you feel, as you were saying, like you're not going to accomplish things because your nutrition is off, your exercise is off. So how do we begin to dial that back and realize that this is not our fault and it's okay to ask for help?
So I'm going to tell you right now, as a doctor, it is not your fault. You were born with it. Let's start there. We need more doctors saying that, though. I have had, in my own experience, and you probably have too, I've had doctors who say, well, obviously you eat too many cookies and breads and pasta and things. That's why you're fat. And it's not the case when I'm eating minimally processed foods that I prepare at home and eating endless vegetables and counting my carb grams, right? There's something else going on. Acknowledging that, I think, is the thing. And really claiming that and starting to develop in a sort of personality and behavior set as a patient. Many of us who are older were taught to respect the doctor, not ask questions. I would say respect the doctor and ask all the questions. If you feel like you're going to be anxious or nervous going in, take a friend or relative with you to help you as a second set of eyes and ears. You can do things like decline to be weighed. There are very, very few reasons we actually need to be weighed in the doctor's office. It can be traumatizing or triggering for many people. No, thank you. Last time I was at the doctor, I said no, thank you 4 times before I was heard.
Yeah.
And kept walking past the scale. Not because I have a problem, because I immediately said my weight out loud in the hallway where anybody could hear it. But I didn't want to be weighed in public in that moment, right? That's the kind of assertive behaviors we need. It goes against what there has been some medical conditioning about. I do see more and more awareness, especially in larger places. Like I go to UCLA a lot for medical care. They're more mindful of it. They're getting that training. But I think that there's a lot of people who do need to maybe have an explanation. And you're not obligated to enlighten everyone as to why you're doing this. But it is something where, to the extent that you can, any little bit that you can do to say, hey, this makes me really uncomfortable. I have history of an eating disorder. Oh, okay. Right. It'll start to click, but we need to have a little bit of resistance to what is assumed to be proper. Ask, why are you telling me this? Why do you want this information? Right? We know now that electronic medical records require them to get our weight, our blood pressure, and our temperature and oxygen saturation rates. This is stupid. I'm there for my migraine injections, right? But that's what they need to do to get paid. Fine, tell me, because I don't want to pay for this. I want my insurance to pay for it. Right. Those are the kinds of things where I think asking why. There's a lot of stuff that's not necessary. Or maybe it is necessary, and they should be able to tell you why it's necessary.
Yeah. And I mean, I that's one thing that I try to tell people is you shouldn't be, I mean, and I know it's hard to do, but you shouldn't be afraid to advocate for yourself or to hold your medical professionals accountable for everything they do, and, explaining why they're doing it, because that could make all the difference in your care. And on the flip side, doctors need to listen, because a lot of time, I think, as patients, we get discounted because we didn't go to medical school. But who is going to know you better than yourself and what you're going through? So I think placing value on our experience and what we've been through matters, right?
Absolutely. And I always tell patients, I am not Dr. God sitting over here in my big throne-like chair, like making pronouncements. You are the expert on you. I can guide you. I can shape how you're thinking, perhaps, if I think you are thinking erroneously about something. I can give you information. I can point you to research. You make your own decisions. I'm not going to decide for you what your care is unless you are in extreme crisis in the moment, and then I will decide. Right. So if somebody was suicidal and they're sitting in my office, I will make the decision for you about what is going to happen next. That is really the only time that would happen, however.
Yeah, and it really is the only time that it should happen is when we ask for the help, then give us the help. So I have a question for you, and I know it's a difficult question, but I would love your insight on this. I have found, like, with a lot of other conditions, even ones that are similar, like diabetes, patients seem to get like a lot of, how do I put this? They seem to be respected for what they're going through. But with PCOS, it's just kind of like sloughed off, and again, we're just told it's our fault. So why do you think PCOS is not taken as seriously as some of these other conditions and what people go through?
Sure. I think for a couple of reasons. One is that we as patients don't really understand how many symptoms are actually associated with PCOS. There are some pretty good lists that circulate periodically about the less known symptoms, but for example, indigestion, dry eye, two really random weird symptoms that I never would have associated with PCOS, but there they are. If you don't know, you don't know what you don't know, right? So part of that is us, but I think the bigger part is the doctors also don't know, because I would venture to say that every single conversation I've ever had with a doctor, with maybe 2.5 exceptions, and I've talked to a lot of doctors over the years, it is downplayed. It is not believed to be something that is radically life-altering, causes disruption in relationships, in school, in work, in parenting. It causes things that are troublesome in every realm of our lives. Instead, what they're taught is this is a reproductive disorder, and the solution is birth control pills and weight loss, and you're probably going to have problems getting pregnant, so come back and see me when you want to do that. That's the whole approach to PCOS, even to the point where, I, as a patient in my 50s, started with a new endocrinologist, and I was mainly there for my type 2 diabetes, which of course is because of PCOS, right? And we went through the list, and she says, oh, so basically, you're not going to have kids at this point in life, so we don't need to talk about PCOS, right? And I just said, yeah, we don't,
Yeah.
because I'm getting a new doctor.
Yeah.
Right.
Yeah.
And that's like one of the best doctors in town.
No, I believe it, because I actually made an appointment to see a new endocrinologist because I too, PCOS, type 2 diabetic at this point, insulin dependent. And I called to make the appointment and they couldn't get me in right away. And I'm like, don't you have anything sooner? And the nurse literally said to me, we don't, but you should be going to see your gynecologist if you're having issues. And I was like, it's not gynecological. Thank you very much. I'll wait another 3 months until I find someone who understands what I'm going through. Mm-hmm. So crazy. So let's talk about some of, I'm sorry, go ahead, Gretchen.
It's frustrating, and there's not a lot of people who actually get it in a complete way, who really understand the mood issues. And I think that there is starting to be a little bit more training, but I have to say that I am underwhelmed with the awareness.
Absolutely. Absolutely. So I wanted to talk a little bit more about mental health symptoms. You touched on a few of them, but what are some of the associated mental health or mood disorders that may be associated with PCOS?
So the term mood disorder broadly covers the realm of anxiety and depression. It also includes things like bipolar disorder, but mostly, which does also affect PCOS patients more than the average non-PCOS patient population. We're mostly looking at depression and anxiety, and those are conditions where they have different looking symptom sets, although sometimes it manifests similarly. So for example, depression is lethargy, lack of motivation, could be sleeping too much or not enough, eating too much or not enough, not wanting to connect with other people, so isolating, could be thinking about death or dying, suicidal thoughts, self-harming behaviors, lack of self-care. Anxiety can often be something that is like a lot of anxiety about the future. It's stress, it's nervousness. It too can result in eating too much for self-soothing, not eating enough because you're so upset your stomach hurts. Could be sleeping too much or not enough for all the same reasons. Less likely to be something where there is suicidal thinking. But mood disorders are in a range. So They're not something hard and fast. Like when you get diagnosed with diabetes, you pop over a certain number and boom, you're a diabetic. That's not quite how it works in depression, anxiety, other mood disorders, but mood disorders do affect PCOS patients much more than other patients. I think of everybody as a patient at this point, but non-PCOS people also get depression and anxiety. It's just that we get it more often. So it's things related to hormone levels. It is frustration. It may be contributing factors of self-loathing, right? When you've been blamed for having this disorder. And many doctors will still say, oh, well, of course you're depressed. You are fat and you can't get pregnant. Well, yes, depressing, right? But we're depressed for other reasons, actually. The externals, like why does the world still say that clothing stops at a size 10 or 12 when the average woman is a 16 or 18? I'm working on that one. Those are also things that contribute to it. The blaming, I think, because anybody who's been through a few doctors has undoubtedly had one who blamed them quite directly, like, you need to stop eating as much and then you won't have this PCOS problem. First of all, totally false. Secondly, way to go with blaming the patient. Patient's here for help. How about you offer something helpful? Right? I think also you asked about why this issue with the medical community. PCOS is not neat and tidy, right? They can put a blood pressure cuff on your arm and go, oh, high blood pressure or borderline hypertension. PCOS, even though it does have distinct diagnostic criteria, has so many potential symptoms and areas of focus for patients that we end up getting parceled out. So if you're losing your hair and dealing with extra hair on your chin, you're probably going to be going to see a dermatologist. Or if you can't get pregnant, you will see a reproductive endocrinologist. Or you are super depressed, you'll come see me. And putting it together, I think, is the thing where it's hard to do, and it's so thoroughly indefinite. And that then means if we don't have a clear-cut diagnosis, how do we develop a treatment plan? If I can't fix you with drugs or surgery, I'm not interested, right? So we see patients who present with a lot of symptoms and their doctors are getting annoyed with them. And I told you, you've got to exercise, until you sweat 60 minutes, 7 days a week. Well, how many of us are able to do that, right? So we give up, we go away. They don't know how badly their interventions are failing.
Yeah,
right?
exactly.
Or like you didn't go back to that office because big fail at the reception level.
Exactly. So what is your thought on when patients seek care, that it's done then as a team approach with mental health addressed, reproductive health addressed, hormonal health addressed?
Yeah, I definitely like to see that some medical practices are starting to do depression and anxiety screening inventories. You can also take those inventories online. If you Google something like depression screening quiz, you'll find some of the instruments that I would actually use. You can take those into your doctor. That's one way to say, hey, this is important, because I know it can be really uncomfortable to raise the issue of something going on that's psychological in nature. It would be, in an ideal world, you'd have half a dozen doctors. You would have an endocrinologist, a reproductive endocrinologist, a dermatologist, a gynecologist, an internist. I'd like to see you with a dietitian and a psychologist also. I'm up to 7. Okay. How many of us are actually capable of doing that? Not so many. Most of us are dealing with an internist or general practitioner and maybe a gynecologist. If you're lucky, you add the endocrinologist in. It's important to make them all aware of what your conditions are, because they may actually know something relevant. If you went to the dermatologist and just said, I'm having this, like my scalp's oily and flaky, but look, and it's not dandruff. Oh, but you have PCOS. Well, maybe there's a whole other thing to look at with that, right? Or it's less of a mystery why you have the hirsutism, or it is less mysterious why you are having GI problems. So that integration if you can find one doctor who actually gets it, get referrals from them. If you can find doctors within the same practice, like there are some practices I know, like University of San Francisco has a PCOS clinic, for example. Those are better places because they're cross-trained and they know what to look for. They know how it might be affecting you. With some of these other issues, though, I think it's something where, again, the level of awareness just really needs to build. So for diabetes, for example, if I had a wound that wasn't healing and I went to the doctor and shows on my chart that I'm a type 2 diabetic, oh, well, that's why diabetics don't heal as well. They would know. But if that wasn't in my chart, they'd be like, I don't know, maybe we should clean it out. You know, maybe I'll put some stuff in it. Maybe I'll sew it up. It's
Right.
like, or we could give it another 5 days and see what happens. Right? This is how diagnosis informs awareness and treatment choices. So again, like if you can get as many of those people as possible, awesome. If you can't, I would aim for an endocrinologist over a gynecologist. If you really can only have one doctor, take the endocrinologist.
Yeah, I would have to probably agree with you on that. And that goes back to the whole thing that we were talking about and that we always talk about, that PCOS is an endocrine issue, not a reproductive issue. So
Right.
let me ask you, looking at PCOS from a therapist perspective. So if somebody comes into you who has not been diagnosed with PCOS and you see depression or anxiety, are there other things that might tip you off to say, hey, this person might have PCOS?
Yes. I have pretty specialized training in some somatic things and reading bodies. I actually can be walking behind you and be like, diabetic, by body type quite often. So I'm not always correct, but when I start to hear certain symptoms that I know because I'm a health psychologist, I will start asking questions about family history, about dieting history, about exercise habits, about sleep, energy levels, all of those sorts of things. So for me, I will say, do a little screening and I'll be like, I'll look at the medication list if I have that. I'll ask questions backing out from that. So I was actually talking to a newly minted therapist the other day who was sort of dazzled by what I was talking about with health psychology. And the reality is that therapists in general are not trained to do much related to the medical conditions, unless it's somebody who is like an oncology specialist. Most of them are taught that, you know, hypothyroidism looks like depression, hyperthyroidism, high thyroid, looks like having the opposite condition. My brain just blanked because I was reading a message that I can only see half of, sorry. But one looks like depression, one looks like anxiety. So hypo looks like depression, hyper looks like anxiety. That's about all the medical psychology training that we get. We may have heard or had some experience that, you know, everybody that has a heart attack ends up depressed. That's about it. We are taught to refer to a medical doctor if we suspect that there is a condition that is medical in basis. Usually that doesn't happen, though, unless we see something like a 50-year-old patient comes to me who seems to be having memory gaps, slurred speech, vertigo. I'm going to be like, better screen for a brain tumor, right? We're probably that good and that comprehensive, but it's almost as bad as it is on the other side, which is probably I've seen 50 doctors in the last 10 years. I think I've had 2 mental health screeners. And I'm ineligible to take them because obviously I'm manipulating.
Right.
But good for them. I do them anyway. And I'm like, hi, I'm a psychologist. You probably want to ask me a couple questions or I'll just tell you I'm feeling anxious today about this appointment. There's just not enough of that. So again, it falls on the patient to bring up symptoms. And again, you don't know what you don't know, right?
Exactly.
I have a rare genetic disorder that, as it turns out, I had no idea was a contributing factor to ulcers. And I was having gastrointestinal pains. And I go to the doctor who just happened to be really well informed and cross-trained. And he says, oh, I see on your chart you have Ehlers-Danlos syndrome. Well, that makes your tissue lining in your stomach thin and weak, and EDS patients get more ulcers. Oh, light bulb moment, right? But I didn't know. I'm a health psychologist. I ask
Right.
these questions all day long, every day.
Yeah.
I didn't know. Now I
Yeah.
know. Now I tell my other patients that have the same disorder.
That's
Right?
great. That's great.
But
And
that's what is missing is a lot.
yeah, no, just, and that's why knowledge and having conversations like this are so vital, so people understand, their options and are empowered to take control of their health.
Mm-hmm.
So another thing that I wanted to talk to you about in the realm, because I know it's a difficult topic and it affects a lot of people. Again, we were talking about a lot of people categorize PCOS as being reproductive and being a women's condition. Well, yes, technically, when you're assigned female at birth,
Mm-hmm.
that makes the condition female. However, a lot of people in the community who are LGBTQ, who are transitioning or have transitioned, find grave difficulty not only with care, but also from other community members who are programmed to think that if you don't identify as female, or if you transition to male, or you have other circumstances, that you can't have PCOS. And that kind of divides the community and isolates this class of patients. So
Mm-hmm.
help. How do we
Okay.
change this?
Yeah. So notice that as I've been talking here, I've almost exclusively used people instead of women. Where I've chosen women or female, it is quite specific why I've chosen to use that word. But here's the reality. We have a very complex landscape around gender and sexuality and the identities associated with those two things. There's an assumption that PCOS is purely a female condition. First off, there is a male phenotype of PCOS where we see people who were born assigned male at birth who have everything about PCOS except the lack of periods, but since they don't have uteruses, they probably were not going to have the periods anyway. But they have the exact same symptom set. So there's that part, right? Then there's the part about the fact that PCOS is a condition of androgens, which are the masculinizing hormones. And in extreme cases in particular, where we see excess androgens, there are many people who at this point in time feel comfortable or more comfortable identifying either as the opposite sex or gender or somewhere in between, right? So you've probably run into people who are using pronouns like they and them. And that means that that is somebody who lives in both worlds, who travels across that space, and or perhaps lives in a third space, which is neither, right? This is super complicated. I am not an expert on this topic, but I do see patients who fit into these categories increasingly. And what happens is that there's a lot of confusion about it and a lot of difficulty. Certainly in larger practices and hospital-based practices, you'll see that more readily addressed in terms of what are your pronouns? How do you identify? But it is something where what I've seen within the PCOS community, and there was at one point a fairly small but active group on Facebook that was specifically for LGBTQ plus PCOS patients. I don't know that it's that active anymore, but I think it is something, if that is who you are, if you still have a uterus, you need gynecological care. You need it from somebody who is comfortable talking to you the way you need to be spoken to. If you're in Los Angeles, I would absolutely refer you to a couple of endocrinologists I know who work a lot with the trans community, or I would refer you to the Los Angeles Gay and Lesbian Center, which has a large medical department that is very well versed in matters of hormonal changes, imbalances, all the things that go with that, because doctors are looking and they're saying, okay, you say you have PCOS, so let's try and get you back to being as feminine as possible. How do we do that? We get the hair off of your face and, you know, so on and so forth. But there are a lot of people now who say, no, I love who I am, beard, you know, bald head, whatever, right? I like the way that having PCOS symptoms makes me feel more aligned with who I actually am.
Yeah.
I don't want to change any of that. And by the way, when I get a period, it's really causing dysphoria, which is a psychological condition. Dysphoria meaning deep distress, discontentment, fear, anxiety about these things related to the body. So I know that that probably sets off a million more questions.
Okay. Oh, yeah, because I know that, I mean, we could probably spend 3 or 4 hours on this with the body dysmorphia and the low
Right.
self-esteem. There's a
million things. I would have to refer you to somebody else who really is an expert on that. I can talk about it in the context of PCOS, but I am not an expert because my pronouns are she, her, hers, right? I am AFAB, assigned female at birth. I identify as female, right? So that's my lived experience. But I think it is something we need to be aware of also, that just because a person looks a certain way doesn't mean they are who you expect them to be.
exactly.
And particularly in the medical and psychological field, and I would say that we are increasingly aware of it and very conscious of it, particularly around the language and what makes people comfortable. But it is things like, you know, do you work in an office building that only has male and female bathrooms? Or do you have one that's marked all genders, right? Those are the kinds of things that can make you more or less comfortable in an environment. So if there's an environment where the forms ask you, what are your pronouns, not to check male or female, for example. And there's a lot, we are so behind on all of this, but I think the awareness around it, and for anyone within the PCOS community, I would say have some kindness and some tolerance. Everybody is living their own journey with this. And the journey through either transitioning or living in a space that is not comfortable for the vast majority of the world, or simply living with PCOS and treating it differently than you are, stop, just be nice, be kind, be curious. And if somebody is angry and frustrated, combative even, doesn't want to pause to educate you, shut up and move on. Go do your own research. It is not their job to take care of you.
Exactly. Thank you so much for saying that, because it's important, just in general with PCOS. I think all of us, because of all of the stress that we deal with, that sometimes it's hard to accept other people's journeys are different than our own. So very important that we support everyone who's going through PCOS, no matter what that looks like for each person.
Yeah, and also that there may be, I've seen PCOS patients who may not even look like the gender they're identifying with, but it is not my job to assess and say, well, you don't look male enough or you don't look female enough. It is my job to accept what you say.
Yeah.
And if you choose to say nothing, it is my job to be okay with it.
Yeah, no, because even in that same context, you have patients who are thin that go into a doctor's office and are told, you are way too thin to have PCOS. There is no way in heck I'm not even going to try to test you for it because that's just bogus. Not, you know, you don't have it. So yeah, there's there's a lot to cover with that.
Yeah, and that's also actually worth noting, because about 20% of PCOS patients are what we call lean PCOS or skinny PCOS. Kind of hate the skinny name, but it is a typically different symptomatic presentation. These are patients who often get overlooked until later in life, usually when they're trying to get pregnant and have problems. They do not typically have as many symptoms in my personal experience. In other words, I see far less of them than I do of patients who have more weight on them. But they are also dealing with a lot of the same things. They have the same hormonal imbalances. They may have the same mood issues.
Absolutely. Yeah. Because the way I understand it, or I've seen the difference, is the lean PCOS patients typically deal with more symptoms of androgen excess, or the excess male hormones, as they're known. Typically, patients who are overweight with PCOS are dealing more with insulin sensitivity or insulin resistance. So
That's a good way to break it out. Yeah.
yeah, yeah. But that doesn't mean that lean patients don't have some form of insulin resistance. They just have maybe less than someone else who's struggling with weight.
Exactly.
So I would love you to give a few final words of advice to everyone as far as something that they can do, a step that they can take to start thinking about things differently and help if they're having a bad day.
Okay. I would say the number one thing I actually would love for everyone to do is go online and pull a depression screener or a mood disorder screener. Look for that. They're all over the place. The one that I would typically use in my practice is called a Beck's Depression Inventory, a BDI. There's also Beck's Anxiety Inventory. They're, whatever it is, free for the public to access. Maybe you don't think you have a mood disorder, but when you see the symptoms on a list, you realize that maybe you do have something going on. And it contributes to how you're doing physically also, because if you're depressed, if you're anxious, you're probably not going to take as good care of yourself. You may not have the energy or the motivation or the desire to. You may feel hopeless, which is a hallmark of depression. This is an easy thing to do. In an ideal world, I would love for every internist or general practitioner's office to do this every time someone comes in, because it can change. We might literally give them every week for a patient. Get a sense of it. What are the things I might be paying attention to myself for, right? Because we need to be the experts on ourselves. If I was having a struggle, I, of course, would be the first to call a therapist or a psychiatrist for myself, because I know all the symptoms on the checklist. Most people don't. Get familiar with them. See what it says. Don't self-diagnose, but it's a cue to find a doctor, find a therapist, and get some additional information and assessment. It'll be really empowering also to know, because once you start seeing some of the things that may be affecting you this way, we could spend a lot of time working on sleep, which would hugely affect everything in a positive way. Or we might want to start shifting something in terms of energy, exercise, movement, daylight exposure, right? Those are things where when you start to look at that, I think that's really the ultimate self-care. If I'm not getting it from my doctor, I'm going to figure it out for myself.
Yeah.
And beyond that, things that I think everybody should be doing is getting a little sunlight, a little movement every day. If you don't have something that's dissociative in nature, like schizophrenia, a little meditation every day.
Love, love, love it. That is so awesome. And everyone, I have to tell you, I read Gretchen's book, and definitely, if you have not read it, please do, because it is transformative. It really is. I loved it. And it's just, it answers a lot of questions about PCOS and self, and how we're doing and how we're dealing with it. So check that out. And Gretchen, if you could let everybody know how else they can find you on social media or your website.
I'm on PCOS Psychology is on the Facebook page, and that's where most of the information gets dropped now. You'll also find me on LinkedIn. Don't follow me on Instagram, because there hasn't been anything posted in a while except for pictures of my shoes, which is not helpful.
But I live for those.
Thank you. Also, I would say with the book, it really is like a comprehensive guide. I wanted it to be like the one-stop shop for figuring out how the role of mental health affects and plays into. The name of the book, Melissa, is The PCOS Mood Cure, Your Guide to Ending the Emotional Roller Coaster. Thank you. Somebody else loves my shoe selfies. And I have kept the price of the book. I don't control the price of the print book, but the electronic version of the book is $3.99. If you cannot give up one trip to Starbucks this month to buy this book, I cannot help you. The book has about 25 pages in the back of supplements, and we all know that supplements are a hot topic in the PCOS world. It's also, it's got my story in it if you are dying to know more about me personally, which is kind of useful because it's a snapshot in time of the PCOS world. But it also describes in detail all of the different mood disorders, eating disorders. It also has some relevant things you can start to do around movement, around getting anger out, a whole bunch of stuff around sleep, 2 full chapters on sleep. So, I hope it's helpful for you. And that's where you'll find me. PCOS Psychology on Facebook is where I answer questions, and anybody's welcome to join. It's free.
Awesome. And there's just one question that I wanted to answer that came in. Somebody had asked, if you are trying to conceive, is it better to go to an endocrinologist or a gynecologist? Actually, me personally, I would recommend going to a reproductive endocrinologist, which is actually the best of both worlds combined. And they are usually pretty knowledgeable about PCOS. They see a lot of it. Gretchen, what are your thoughts on that?
Yeah, absolutely. Some gynecologists are well-versed in this, some endocrinologists are, but if you want to just go straight to it, you're always going to end up with a reproductive endocrinologist anyway. In Los Angeles, my personal RE was board certified in both gynecology and endocrinology, and they see PCOS patients all day, every day, because we are, just like with electrolysis, PCOS patients are one of the primary consumers of reproductive endocrinology services. So might as well go straight for the person who knows everything about it and knows how to counterbalance anything that's a problem for you.
Right. And that's another thing for people who are not trying to conceive. There are a lot of reproductive endocrinologists who will still see PCOS patients, even if you're not interested in getting pregnant. So don't shy away just because it says reproductive endocrinologist.
Yes.
I found the best care through RE.
I find them to be the single most knowledgeable group about PCOS.
Absolutely. Well, Gretchen, I had an absolute blast talking with you this evening. And like I said, it wouldn't be PCOS Awareness Month unless the two of us sat down and talked had a little kiki before the month. So thank you so much for always being so informative and supportive and joining me this evening. And this live will be living on my Instagram page, and I will tag you. And I hope that in the future you will join me again for more information and we can tackle some of these other topics.
Great. I noticed there were a couple comments coming in here and there. If you had a question that was posed to us and did not get addressed, please do send me a message. Preferably through Facebook is the easiest place for me to answer it back. I'm not super adept on the Instagram thing.
But you have this IG Live like a pro, so I love it. Yeah.
Okay. It was fun talking to you as well. Thank you.
Thank you so much. Have a good night. And gang, there are a few more lives coming in for the rest of the week, so tune in and follow my feed to learn more. Have a great night, everybody. Bye-bye.
Bye. Bye.